I'm Venous Stenting. I'm one of the vascular surgeons here at Mount Sinai. Maytherna has been a major part of my practice. I've seen many of these patients. So I'm going to go over some of the data that we have. This is my disclosure. And there's a picture of Mount Sinai. Everything looks beautiful from an elevation and in the dark, right? So from October 2013 to July 2016, we performed 484 patients with venous stenting in the iliac veins. So all these patients were chronic, non-thrombotic, venous outflow obstruction, all in the iliac veins. So the mean age was 60 years. The youngest patient was 19, and the oldest patient was 91. Clearly, we don't recommend doing vein stenting in patients who are very young, but there are exceptions to this rule. 57% of the patients were female, 43% male, and bilateral stents were performed in around 59%. We had really great follow-up. And 90% of patients were at least seen once. And many of these patients continue to be seen by me and my colleagues. And the mean follow-up, when we look at this data, was 320 days. So this is really powerful information because not only do we put stents in these patients, we're able to see this patient in follow-up over several years. So we know how these patients do over a period of time. These patients, they present with very discrete type of clinical scenarios. The case that we mentioned, that we did earlier, was a patient who had recurrent symptoms after a prior endovenous laser ablation. That is a common scenario. But here on the slide is some of the symptoms that these patients have. Clearly, edema is very prevalent among these patients, 90%. About 10% of patients, 11% of patients had active ulceration. Not surprisingly, about 14% of these patients had a history of DVT in the past, or known history of DVT in the past. What's interesting to me is that there were also many patients who had DVT in the past that were not known to the patient. We found this during venogram, with the venogram and also with the Ivars. So how these lesions differ from compression. These lesions are usually very diffuse. Sometime where we see debris in the lumen of the veins. In some of these patients, the veins are completely thrombosed. So we know these patients, at least part of the obstruction is due to intraluminal thrombus in the past. We looked at SEEP class of these patients. Not surprisingly, SEEP3 is very common, most of the patients. And then once again, 11% of the patients had active ulceration at the time of the intervention. You can do any kind of cross-sectional imaging on this patient, CT venogram and MR venogram. I have a personal preference for MR venogram. Here you see pretty extensive compression of the left common iliac vein. And so almost every patient, unless contraindicated, will undergo a preoperative MR venogram. And as mentioned, is when you do venography on these patients, you frequently don't see the actual stenosis. But nonetheless, it's an integral part of the imaging during the intervention. And here we see lots and lots of Calero, left to right Calero, and you see some filling. I think this is a common iliac vein. So the Calero is a tip-off that there is a proximal obstruction. And the Ivars is, as we all know, is extremely useful in these patients. So we can actually see the stenosis. We can measure the degree of stenosis, and allow us to measure the extent of the stenosis. Here on the right side, you see an external iliac vein that's very, very stenotic. And this is a reference vessel in the same patient. And these are some of the stent configurations that we had used. Here is a pretty straightforward. There's a stent extending into a very proximal vena cava, and then extending distally into the common iliac vein. And in this patient, we did bilateral iliac kissing stents. So how do we follow these patients? Clearly symptoms, how they do afterward, sleep class, and physical exam. But having taken care of many of these patients over the years, I think the best way to follow these patients is by symptoms. If they have recurrence of symptoms, persistent symptoms, it tells you something is wrong. So we see this patient 30 days, 90 days, 6 months, a year, and greater than 1 year. And we give them a clinical assessment score. -1, worse than before stent. 0 is no change. +1 is minor improvement. +2 is major improvement. And +3 is normal. So this is a very busy slide. So on the top here is different, the clinical assessment. -1, 0, +1, +2, and +3. And here is at 30 days, 60 days, 6 months, 1 year, greater than almost 2 years. So almost no patient did worse than before their stents. You look at 30 days, 14% report no change from their pre-stent status. 34% reported mild improvement. About half the patient report their legs are much, much better. And about 5% of the patient report them completely recover. If you move this down 1 year, about 15% of the patients reported that their symptoms are about the same as before we didn't have anything done. And 33% of the patients reported mild improvement, 27% of patients reported significant improvement, and 27% said they will completely recover from before. We took some of these patients back. Out of the 461 patients, we took 34 patients back for a second look and some additional intervention. So it's around 7% now. Now there's 2 additional years out, so that number is up to around 10%. Clearly, a history of DVT or finding of DVT during surgery increases the risk of a second look operation. There are different reasons for taking these patients back. The most common was recurrence of symptoms. So here I have a patient said, "Doctor, I was doing great. And then I noticed in the last month that my swelling that I had before has returned." So we know there's something wrong with that patient. So in conclusion, there are distinct clinical presentation of these patients. Intraoperative finding of post-phlebitic vascular changes, a little more common than we anticipated. And most of these patients do relatively well at 1 year. And reintervention, second look, in about 7 to 10% of these patients after their initial intervention. Thank you.